members amongst young and junior doctors. And we have a very rich faculty today, and we are pleased to welcome you, and we will be very pleased to welcome you and can urge you to consider membership in the ISPN. I'm very pleased to co-chair the session with my colleague and friend, Dr. Artur da Cunha. And Artur, would you care to outline the program just a little bit and maybe introduce our first speaker?
Okay, welcome everyone. Good morning, good afternoon, and good evening, wherever you are. Yes, we start now with the first presentation. Yeah, is Dr. Ramiro. Dr. Ramiro del Rio is a pediatric neurosurgeon in Buenos Aires, Argentina. Work in the very known hospital in Argentina, the Garahans. And after Dr. Del Rio, we have Dr. Jeffrey, is the chair of the Education Committee from ISPN. And come Dr. Tatiana Prosenko, yeah, from Rio de Janeiro, is also a very known pediatric neurosurgeon in Brazil and in the ISPN also. And me, I work here in Recife, in the northeast from Brazil. I'm a pediatric also neurosurgeon. Yeah, and we can start now. Jeffrey, we start with you or with Ramiro?
No, I'm happy to start. Mine will just lay it out from a very elementary perspective, and I think Ramiro will give some very basic, give a much more substantive course. Let me see if I can share my screen here.
Okay.
I just need to be in presentation mode, which I believe will be there. Yes. Are you seeing my screen nicely?
Perfect.
Thank you very much.
Perfect.
So my name again is Jeffrey Blount, and I'm from the United States. I'm going to outline just a couple of case studies and raise just some very simple questions in just a few minutes here to get our program off. I'm going to start with sort of the simplest of concepts, and I'm going to then turn to one of the more challenging concepts, and I'm going to limit myself to these two things. So this is a case that occurred. It's fairly straightforward. A pediatrician who serves an underserved rural area in our catchment area called us out of concern that a baby who he had seen once for a well child check and seemed to be doing well with a modestly large head had taken an enormous bump, an 8-centimeter jump in head size in about 2 to 3 months' time. So that's a tremendous trajectory of growth, not just the rate and size of the growth. Interestingly, the only thing that the pediatrician noted of note in the baby's history was that the child had been born under circumstances of a bit of a prolonged labor, some fetal distress, stuck in the birth canal, and the delivery was traumatic both to the child and to the mother. The child required about 4 or 5 days of support in the ICU, but was born at term. The mother required some surgery, but ultimately both did well and went home. So as I said, previously the head size was at the 79th percentile. The child had a humeral fracture that was healing, that had been evaluated by orthopedics without imaging, but at the 5-month checkup, the head circumference had jumped enormously to 51 centimeters. And so this is actually privacy. Privacy precludes me from actually sending a photo of this baby, but this baby looked very much like the photograph that I'm showing here. This baby had a towering head with a very firm fontanelle. This baby had a downward gaze preference and was absolutely unconsolable, right? And fussy and kind of high-pitched screaming cry. occasionally having emesis, but was keeping food down reasonably well, okay? So I don't think the diagnosis is much in question here, right? In a modern era when we can get a scan, we see these very large ventricles, which in the context of a bulging fontanelle, a fussy baby with downward gaze, clearly indicates that this child has hydrocephalus. So the most basic issues to consider at the very beginning are, does this baby need to be admitted? Does this baby need to be boarded close to the hospital, but not necessarily inpatient? Or do we allow the child to go home? And then, of course, what's our choice of intervention, right? So we think the most simple things in terms of either we do a shunt, which is tried and true, well chosen, but we can't just say we're just going to pop a shunt in, because there are things that we have to consider. What's our choice of approach? Do we do a frontal approach? Do we do a coronal approach? Is one preferable? Is the thin skin of a tight scalp like this preclude us from doing any more incisions than we need to? Often a retroauricular behind the ear incision is needed with a frontal approach. Sometimes it's easy to put the catheter in the temporal horn when you go from an occipital approach in big ventricles like this. Does that matter? What choice of valve are you going to use? I remind you that these ventricles are very, very small, and the choice of valve could be important because we don't want to create one problem while we fix another. Programmable valve or sigma valve, which is flow regulated, may be better than a differential pressure valve. There's lots of opinions about valves. What about positioning this child? Positioning the child in extreme macrocephaly can be a difficult thing. So even in the simplest of cases, there are important nuances. And these are some of the things that we're going to talk about and think about. If one is going to do an ETV in a situation, is the anatomy conducive? Does one choose a rigid or flexible scope? Each one brings advantages. What about coagulation of the choroid plexus? Doing a choroid plexus cauterization at the same time as the ETV has been shown to be very effective in infants with post-infectious hydrocephalus, but not so much in infants with preemie IVH-related hydrocephalus. And again, other nuanced conditions. So of course, it's a question of shunts or ETV CPC to think about, right? And different answers might occur in different places. And this is where I want to just at least mention that in North America, there's a trial that's a randomized trial that's going on. It's called the ESTHI trial. And that trial is enrolling patients right now, trying to help discern the preference for which babies do better for situations where we have equipoise, which is to say that we think that there's equally good options for ETV or ETV CPC versus a shunt. This is a randomized trial that's ongoing right now under the auspices of the Hydrocephalus Research Network. It's scheduled to continue to accrue for another year and a half, and then it will hopefully have an answer, and it's coordinated by the Hydrocephalus Research Network. So there is a prospective trial that's ongoing right now. Okay, so that's just kind of a, dip your toe in the most obvious. Here's a little bit more nuanced question, okay? And I present this as a pair of cases, and the cases are presented today for food for thought, not necessarily to ask a question that derives a right or wrong answer. But these two patients are very, very similar. They're both less than a year old. They've both demonstrated progressive head enlargement. They both remarkably large ventricles on scan, and they were treated via different ways. One patient, the baby on the left, was treated with a VP shunt, and the baby on the right was treated with an ETV CPC. And this is what they did following treatment. Now, this is a published case, okay? So the baby on the left has done what shunted patients often do. If you look at the CT scan, you can see that the ventricles are decreased in size. In fact, the cortical mantle has come down a little bit from the dura. The head growth curve has absolutely flattened. You can see on the left side of the curve of the growth, it's going up at a very steep rate. The shunt is inserted sometime around this point, and then you've got a relatively flat curve that traverses the normal range, but is now, with this flat curve indicating complete lack of growth, is now actually in the smaller parts of the curve. So by contrast, the baby treated with ETV CPC has larger ventricles and a larger head that is paralleling the curve, but not any longer in the normal range. But for these procedures, a growth curve that parallels the normal curve is accepted as an acceptable outcome. And the preliminary data at this point in time is that the cognitive outcomes are essentially equivalent. Now, that's based on still early Bayley's 3 developmental quotient level of outcome studies. But at the present time, the best data is that there's not significant difference. So in VP shunts, head growth is flat. Are slit ventricles too small? Is that an adverse outcome? The baby treated with a shunt, of course, lives the shunt life with the longitudinal risk of shunt failure. Everybody's very familiar with that. Some children do well with shunts. Many children require shunt revisions if they have a shunt placed. Chronic headache is a problem in a variable percentage depending on the series. These are real morbidities. What about the ETV CPC? No shunt, so they don't have to lead the shunt life. Low risk of failure. It's not zero. Some ETV CPCs can fail, but it appears to be a very small percent. But what about this long-term potential risk on cognition? And then to develop this, I'll just take this just one step further, and I'm going to leave it here and leave it to my colleagues to discuss some of these issues. Look at the curve on the left. You see how flat that is? Now, if that curve stays flat, that's going to keep that head well below the normal range and has the potential for the so-called overshunting and multiple fused suture situation where you get a craniocephalic disproportion down line that makes for very brittle shunt dynamics. How flat is too flat? How small is too small for ventricles? Are slit ventricles the objective for placement of a shunt? We don't specifically control that. Does that warrant or support the use of programmable valves to try and navigate the child through the range, as some of our colleagues in Berlin and other places have advocated? Now, what about ETV CPC? This curve seems to be beginning to deviate even farther from the norm. How large is acceptable in ETV CPC? What are the hallmarks for failure? So we have some easy answers, and we have some very difficult questions that still remain in pediatric treatment of hydrocephalus. So with that, I'm going to turn it over. Artur is, who's speaking next, Artur? I think it's Ramiro, is that right? I think Ramiro is going to pick it up from here.
Yes, it's Ramiro.
Okay. I'm done sharing. Ramiro, can you share, or am I blocking you?
Let me see. So it will be screen 2. Okay, can you see?
Yes, very nicely. It looks great.
Okay, thank you. So thank you very much. Thank you, Jeffrey, and thank you, Artur, for the invitation to be here. Now I'm going to talk about the theology of the hydrocephalus. It's a theoretical subject, but I think it's important in order to decide the treatment. So, well, first of all, to understand the etiopathogenesis of the hydrocephalus, we need to know the dynamic of the cerebrospinal fluid. So it is first produced, then circulates, and then is absorbed. So we can't have any problem in all of these points. So the first thing we can have is an hyperproduction of the fluid. It's not common, but we can have that, as we're going to see later. Then there can be an obstruction or a stop in the circulation of the liquid at any time, or then we may have a resistance of absorption. So all the etiologies of the hydrocephalus must be put in one of these 3. So now we're going to see a list of etiologies. It's a long list, but we are going to try to understand them so we don't have to memorize all the list of these etiologies. As we know, we are talking about pediatrics, so we must have some congenital disease that are producing hydrocephalus. And then, of course, if we have congenital, we will have an acquired disease. Talking about congenital disease, we can divide them in a simple causes of hydrocephalus. Congenital causes, simple congenital causes may be because an obstruction of the aqueduct or the foramen of Monroe, or maybe just the problem is in the pachyonic granulations. Then we will have the genesis that we're talking about malformations of the CNS. So talking about malformation, we'll have all these causes. The first one, The first two ones of these are, of course, hydrocephalus disease, and the other one may cause hydrocephalus, or cannot have hydrocephalus. It depends on the type of malformation. And then we have congenital secondary causes. I mean, so these are causes that started during the pregnancy, and then we have the tumors that the baby are born with some kind of tumors that can produce hydrocephalus. We also may have in premature babies that should be in the uterus. They are premature, so they may have an hemorrhage, and of course prenatal infections. If we are talking to acquire etiologies, it's easy because almost everything in the central nervous system can give hydrocephalus: tumors, infections, hemorrhage, and tumors. So these are all the etiologies of the hydrocephalus. So just going a little bit to a classification, I think it's better to know this classification based on the CSF circulation. How we classify them? Well, we can classify them first of all, with the hyperproduction, as we see in the first slide. So there are certain choroid plexus tumors that can produce CSF. They are the producer of a CSF. So these tumors are like enlarged choroid plexus organs, so they can produce a lot of CSF, more than the sinus venous can absorb, so they may lead to hydrocephalus. Then we have a division between non-communicating hydrocephalus and communicating hydrocephalus. I think that's really important in order to decide a treatment. So if we see the circulation of the liquid, we can see that there are certain points that are narrower than other. So in those points that the ventricles are narrower, they can stop, the CSF can stop. So there we will see this kind of non-communicating hydrocephalus. And of course, communicating hydrocephalus, we have all the system connected, but however, the CSF cannot be absorbed. That may be of blocking the surrounding space, or maybe because of there's more pressure in the venous sinus than in the CSF, so the liquid cannot pass through the pachyonic granulations. So talking about communicating hydrocephalus, first of all, we will have the post-hemorrhagic. I'm going to show images from a premature baby, but I think that this can be applied in order of etiology to all the patients with post-hemorrhagic hydrocephalus. So this is an ultrasound of a premature baby. We can see there the clot, and we also can see that there is an hydrocephalus. Maybe at the first time, this hydrocephalus can be non-communicating because the clot is blocking some of the foramina, but after a time, this clot is absorbed. You can see here the porencephalic cavity, but we still have all this hydrocephalus. So why is that? Because there's a lack of absorption of the CSF in the cerebral space. So there, after the post-hemorrhagic, we can have this kind of evolutive post-hemorrhagic hydrocephalus. Here you can see the transependymal edema, the enlarged ventricles. So this is the most common, and this is the same we see after malformations, bleeding inside the ventricles, or trauma bleeding in the ventricles. We can see this kind of evolutive hydrocephalus, but also in the preborn, the premature baby, we also can find another kind of ventricular enlargement. This is the one. This is not really an hydrocephalus because this is due to encephalomalacia, so it's an ex vacuo enlargement of the ventricles. There's not high pressure, but just an atrophy of the brain. And the last one we can see also in the premature baby is the cystic periventricular leukomalacia, as we can see here. Yeah, you see a cyst connected to the ventricles where was the bleeding first. So this is the post-hemorrhagic communicating hydrocephalus, and the other frequent cause of communicating hydrocephalus could be the infections. So we also have congenital here. We have what we call the torch, the infections of torch during the pregnancy. That's toxoplasma, rubella, cytomegalovirus, and herpes simple virus. All those can cause congenital hydrocephalus. And this is an example of a CT of baby with congenital toxoplasmosis. There you can see the enlargement of the ventricle, a communicating hydrocephalus, and something characteristic is all these calcifications surrounding the ventricles. So then we can have, after the baby is born, we can have post-meningitis hydrocephalus. That's because of a blockage of the subarachnoid space because of all that pyogenic stuff, and all the inflammation process will produce a stop in the circulations through the subarachnoid space of the CSF. And there we have a patient. This is not big ventricles, but however, if we compare that with the previous CT, there were really an enlargement, progressive enlargement of the ventricles, and also you can see the lack of subarachnoid space. So this is another kind of communicating hydrocephalus. The one is produced post-meningitis. As you know, the post-meningitis you may have during the newborn baby, the newborn process, or you may have it in older children. And the last of post-infectic as the post-pyogenic ventriculitis, most of them are because of an infection of an external drainage or of an infection of a shunt. They may cause a pyogenic ventriculitis, and that ventriculitis also can make us a lot of septums inside the ventricles, something like this. You can see here a lot of septums inside that. So here we have mixed causes, not only communicating hydrocephalus, but also some of these cysts may be blocked inside the ventricles. So this is a complex. It's complex for the etiopathogenesis, but it's also complex for the treatment because you have to communicate all the cysts to avoid the catheteres. So if you can connect all the cysts, you may have only one ventricular catheter, but if you have some excluded cyst, you may also need another catheters. Well, going to the communicating hydrocephalus, I mentioned here another cause, that is the hyperproduction of the CSF. Of course, it's because of something of the plexus choroideum, the organ that produces this CSF. And well, we have here an example, choroid plexus tumor. This tumor is not blocking anything, but it's just producing CSF, and there you can see the hydrocephalus. This is a choroid plexus papilloma. Well, talking about supratentorial nerve communicating, well, as we see, there are many of them, and it depends on the place where the CSF stops. Here we have an example. This is an unilateral hydrocephalus. So, yes, so here we have a obstruction of the foramen of Monro. This is a SIGA tumor, a subependymal gigant astrocytoma, von Willebrand syndrome. So only one foramen of Monro is blocked. So you have enlargement of only one lateral ventricle. See that the other, it has a normal size. So this is the first supratentorial non-communicating hydrocephalus. Then we will have the enlargement of both lateral ventricles, but not of the third. The third here has a cyst that cyst is blocking both Monro foramens. You can see here the enlargement of those Monro foramina, and this is caused most of the time by a third ventricle or a midline tumor or something that's here blocking those both foramen of Monro. And well, last we have what we call the triventricular hydrocephalus. If you can see here, you have a dilated lateral ventricle. You here can see the corpus callosum rather thin. Then you have also a bulging third ventricle, and there you have the open aqueduct and a really small fourth ventricle. So the CSF is not reaching the fourth ventricle. And why is that? Because that bacteria was a tumor. Then we will have also this other patient with a small fourth ventricle and an enlargement of the lateral ventricles. We can see that for the shape that is a baby. And here we don't see the aqueduct. Remember, here we have it really enlarged. Here we don't see it. So this is a congenital situation with a aqueduct stenosis. And here we have another problem in the aqueduct. That problem is that we have a tumor, but a supratentorial tumor in the pineal region or in the tectal zone that can block the aqueduct. So if we can see, all the block of the circulation of the CSF are in the narrow path of the aqueduct. So the aqueduct stenosis and the pineal or tectal tumors. So how do we think when we have a supratentorial hydrocephalus? Well, we know that we can have congenital, we can have tumor, or we can have cyst. So if we have unilateral hydrocephalus, only one ventricle, we've seen that is a fraction of only one foramen of Monro. We have the trace of one foramen of Monro. It's not common, but we can have that. And we can also, of course, have a tumor like a SIGA or a cyst. Then we have the bilateral. The bilateral, most of the time, is you have the occupation of the third ventricle, and the reason is a tumor of a cyst. And then in the triventricular hydrocephalus, we can have a problem in the aqueduct. That problem can be congenital, the stenosis of the aqueduct, or you can have a pineal or a tectal tumor. And also you can have a obstruction in the fourth ventricle. Most of the time is that because of a tumor or a cyst also. We have some congenital cysts, as we're going to see now. Talking about congenital cyst, well, the diagenesis pathology is here. You have a big cyst in the posterior fossa, is blocking the liquid to go into the subarachnoid space, Luschka margin, the foramina. And if we see in the axial section, we can see the cyst, but also we see an agenesia of the cerebellum vermis. So this is what we call Dandy Walker disease, and it's a kind of not communicating hydrocephalus because of the cyst. And it was demonstrated that the surgery on the cyst is not good to resolve the hydrocephalus. So a third ventriculostomy is the first best procedure, and that shows that it's a kind of non-communicating hydrocephalus. Also, we have another malformation, not a common with hydrocephalus, but sometimes may produce hydrocephalus. This is a Chiari malformation. You can see the tonsils here protruding through the occipital foramen, and it were two theories about why this patient with Chiari malformation may have hydrocephalus. One is because the small posterior fossa increasing the pressure of the venal sinus, and the kind of theory. But it's true that some of this patient after the third ventriculostomy may improve. So there's more a theory now accepted of the block of the Luschka and Marchand foramina. And last, just to mention the communicating diagenesis. This is, as we can see, there's no frontal lobe. So this is called an holoprosencephaly. This is the most severe classification of the holoprosencephaly malformation. And then we have this patient without any cortical parenchyma, which I have the encephalum. This is called the hydranencephaly, another kind of communicating hydrocephalus with bad prognosis. Well, just to summarize, I'm on time. Hydrocephalus etiology, just to understand that the hydrocephalus etiology, first we have to think is if a congenital hydrocephalus, this is a small baby, or it is acquired, if the patient have any kind of bleeding or infection, or if there is a tumor inside. Here we have the difference between all those two kind of hydrocephalus. And then thinking about the pathophysiology that will lead us to the treatment, we have to think it's if it is a communicating or a non-communicating hydrocephalus. I think that's the most important thing. And if there is an obstruction, where is the obstruction? So this is, I think, important, because an accurate diagnosis may lead you to the best treatment for that patient, as Jeffrey said before. Well, thank you very much for those who are in Latin America, and just to invite you next year to this course of 1 week. All of the faculties are from the ISPN, so I think it's a nice opportunity to continue discussing this. Thank you very much for your attention.
Ramiro, what a lovely summary. Yeah, what a fantastic summary. It's really beautiful. There are a couple of questions that we are noticing. In the question and answer period, there are several talks coming about ETV. So we're not going to take a moment to do that right now, but rather to hear our next presentation. Okay, Artur, could you introduce our next speaker?
So the next speaker is me, yeah. And let me
Perfect.
share. Okay. Did
Lovely.
you see my presentation?
Very nicely.
Very nice. Okay, good. So, hi everyone. Thank you for joining us on this ISPN webinar. And what do you know about hydrocephalus treatment, about shunts, about ETV? Every year, almost 400,000 new cases of pediatric hydrocephalus are diagnosed globally. Hydrocephalus occupy around 40 to 60% of pediatric neurosurgery agenda. At the beginning of 20th century, ventricular shunts emerged, offering hope for the treatment of hydrocephalus. In 1949, Knudsen and Spitze successfully implanted a vena cava shunt with a ball valve. Between 1955 and 1960, distal slit, proximal slit, and diaphragm shunt appeared. Around the 1960s, the invention of silicone shunts led to a worldwide therapeutic breakthrough. Nowadays, there are several models, from the simplest to the most technologically sophisticated shunt. Ventriculoperitoneal shunt is the most commonly used technique today. The second most commonly used option is ventricular atrial shunt. As I said before, hydrocephalus occupies around 40 to 6% of the pediatric neurosurgery agenda, but in 50% of cases deals with shunt complications. The younger the patient, the greater the risk of mechanical or infectious dysfunction. And the failure rate during the first year of shunt implantation remains, even in the best hands, between 20 and 40%. The history of the patient with a shunt for hydrocephalus treatment is usually marked by several hospitalizations, surgeries, and a progressive deterioration in the quality of life. All of this with a high economic and social cost. Despite the complication, ventriculoperitoneal shunt remains the most frequent treatment for hydrocephalus, as Dr. Jeffrey and Dr. Ramiro said before. Neuroendoscopy, as we know it today, emerged in 1990 with the use of neuroendoscopy. A bypass could be created through the floor of the third ventricle, diverting the CSF to the subarachnoid space. Modern neuroendoscopes, video systems with a high resolution image, intraoperative ultrasound, and neuronavigation, among other tools, have allowed safer approach and better results in performing third ventricular cystinostomy. Despite some controversy, the endoscopic alternative in the treatment of hydrocephalus has been increasingly used both in the primary and secondary approach after shunt complications. But if we look at the early international literature, considering the patient etiology and age, we won't find different results. Some of them not encouraging. There is almost a consensus that ETV should be the primary treatment for obstructive hydrocephalus, especially aqueductal stenosis. ETV as the primary treatment for myelomeningocele associated hydrocephalus was still highly controversial. There was greater controversy regarding the indication of ETV in hydrocephalus secondary to infections and intraventricular bleeding. And some publications have mentioned that there are no difference in outcome between treatment with shunt implantation and ETV. As Dr. Jeffrey showed before, Abaya, in this prospective multicenter study, considering the patient age, etiology of hydrocephalus, and the previous shunt's existence, proposed a predictive table for the success of ETV. In this table, the higher the score, the greater the chance of success in ETV. However, If we follow this table, most of our patients have a bad prognosis because most of them are in the first year of life, and 40 to 60% are associated with myelomeningocele. And even if we consider older children, we will find a large group that has already undergone shunt review. So coagulation of choroid plexus, despite being a technique already known since 1918, used by Dundee Putman, among others, was initially abandoned because of serious complications. In the early 2000s, Benjamin Worth made the approach of the choroid plexus reborn and demonstrate good results in ETV plus choroid plexus cauterization, association with exceptional results in very young patients. As you can see here, some data from his publication in 2005, results of his work at the Cure Children's Hospital of Uganda. In another paper, he compared ETV with ETV plus CPC, demonstrate better results in the second group. In other publications about studies in Uganda, Worth and collaborators demonstrate similarly good outcome in patients with Dendy-Walker syndrome, encephalocele, and aqueductal stenosis. In this article published this year, Worth reviewed the record of 348 patients younger than 12 months of age who underwent initial treatment for hydrocephalus via ETV plus CPC or VPS placement at Boston Children's Hospital between December 2008 and August 2021. He obtained results similar to those observed in Uganda. In between, our summary, the international literature collected many papers that show convincing results in ETV and ETV plus CPC. The ETV and the ETV plus CPC have the advantage, restore the CSF circulation in a natural way, reduce the transmantle pulsatile stress by increasing compliant ventricular wall, not affected by position, don't need hardware. If necessary, we can repeat the approach. Low infection rate, and we can treat with antibiotic without a new surgery. And decrease CSF production and minimize the effect of malabsorption syndrome. But as disadvantage, we have long surgical time, difficult to assess the entire choroid plexus, sometimes, especially if we use the rigid endoscope. Sometimes a septostomy is necessary, prolonged hospital stay, late failure with even catastrophic result is very infrequent, but sometimes we observe this so-called arrest hydrocephalus. So the patient's age is perhaps the major factor in the success rate of TB. Patients younger than 6 months do not achieve a success rate above 40%, is in our experience. The results of ETV are significantly better in triventricular obstructive hydrocephalus. I have not observed that the history of multiple shunt reviews and the shunt duration influence secondary ETV success rates in shunt malfunction. In many cases, it requires a long hospital stay due to the need for monitoring with external lumbar drainage. The shunt over drainage and slit ventricle syndrome is always a big challenge. The neuronavigation is indispensable in this case. Regarding the dysfunction of the shunt associated with infection, some articles have shown that secondary ETV results are superior to primary ETV. That indicates a shunt dysfunction associated with infection. The addition of choroid plexus coagulation can improve the outcome in many cases. The complications of ETV or ETV-CPC are similar. Perforation of the basilar artery and injury of the third cranial nerve are hard and may be associated with thick floor of the third ventricle and the presence of fibrosis in the cistern. Small venous bleeds are easily resolved with irrigation. Endocrinological disorders are more frequent in secondary ETV due to the possible involvement of tubercinarium, a component of hypothalamic pituitary axis. Small subdural collection usually resolve spontaneously. Wound breakage and CSF leak with consequent infection are the main cause of failure in ETV. Prophylactic antibiotics are given only during anesthetic induction. Early or late seizure occur in 20 to 40% of cases. It's more frequent in case of cauterization of the choroid plexus. A new approach can solve late failure like closing cystinostomy and formation of a new membrane. In case of ETV plus CPC, following shunt malfunction or the presence of a scar cistern, I recommend ICP monitoring through external lumbar drainage for a couple of days. And I have no experience with sudden death cases. So in this article, published in 2017, Kulkarni reported a study with 100 infants. 51 were randomly assigned to undergo ETV plus CPC, and 49 were assigned to undergo ventriculoperitoneal shunting. The median Bailey scale of infant development cognitive score at 12 months did not differ significantly between the treatment groups. There was no significant difference between the ETV plus CPC group and the ventriculoperitoneal shunt group in the Bailey scale of infant development 3, motor or language scores, rates of treatment failed, or brain volume. I believe that the indication of primary or secondary TB in cases of aqueductal stenosis, post-hemorrhagic, post-infection, and myelomeningocele has already been sufficiently supported by current international experience. I will show a little of our experience with TTV plus CPC. In this series from 2015 to 2022 involving infants and primary treatment of hydrocephalus by aqueduct stenosis, we compared the result of ETV and ETV plus CPC, and we find a better result in the group of ETV plus CPC. So in this video, let me see if we can show you is our technique. First, we do of course, the third ventriculostomy. With a Fogarty catheter. Number 4. Open the membrane. After that, we start with choroid plexus cauterization. Of the right side. Then we do the septostomy. And the plexuchoroid cauterization of the left side. In this case, it was possible to cauterization about 90% of the choroid plexus in the lateral ventricle. So, okay. We are faced now to a big discussion in, is the choroid plexus necessary? What may long-term happen after CPC? This is the big discussion, yeah? Little is known about the physiology and the integrated functional network that choroid plexus is inserted. Most published studies are observation in vitro and animal models. Human studies are limited to adults with a degenerative disease, and there are no comparative studies involving patients undergoing CPC. We developed now in our university, Federal University of Recife, I study with human choroid plexus, just with the case that we do the choroid plexus coagulation. So this is a study that we try to observe it in a long time what happened with our children that we do the plexus choroid coagulation. So to conclusion, ETV plus CPC can be considered a primary treatment modality in children, especially in first year of life. In select cases, secondary ETV plus CPC may be more successful than ETV. The successful result is observed in approximately 40 to 80% of the patient. Of course, depend of the age and the etiology of hydrocephalus and so on. ETV plus CPC failure occur within 1 to 6 months. Incomplete CPC, squared cistern, and infection are frequent causes of procedure failure. Long-term follow-up of this patient is necessary to understand the subsequent response to CPC. The roles and function of the choroid plex are still unclear, and new studies are needed. So thank you very much. And I finish my presentation with a view of Capibaribe River in Recife. Thank you.
Artur, beautiful presentation. And I hope that the observers will recognize the amount of experience that represents that was just shared with you. So you've really heard this now from the very introductory, most basic, to a senior person that's literally done hundreds of these cases and seen the full clinical spectrum. Those were beautiful videos. Artur, there was one question in the question answer period that I think we might take a moment for. We're doing reasonably well with time. Hanak from Ethiopia says they've been doing Dandy Walker with hydrocephalus in Ethiopia, but they saw that some of the procedures failed. Would you like to say anything, particularly in low middle income countries? Infection is an etiology that's very common. Do you have any pearls that you might share with people or observations that you've made that make the difference between whether ETV CPC is successful or not? What do you think are the keys? Are there anything special in specific etiologies to tie these lectures together?
So avoid infection. We always do the prophylactic antibiotic. I think this is very important, especially if we do the choroid plexus coagulation, because the time is more long as a normal ETV. So to prophylaxis, I recommend to do the antibiotic. And this is very important to study the NMR the picture from this patient, because in some case we need to open the Dandy Walker membrane, the Dandy Walker capsule, that we have better results.
Artur, one of the things I think they were alluding to was that many of their patients have their hydrocephalus as a result of a prior infection, right? So you addressed in preventing infection as part of the operative procedure, but sometimes infection gives rise to widespread inflammation and adherence of membranes and difficulty. Are there any points that you think of when navigating some of those difficulties?
Yes, the hydrocephalus associated with infection is a surprise box sometimes, yes? because some patients, they don't need a shunt. We can treat, with EVD, with external ventricular drainage. We can treat the infection with, of course, with antibiotic, and not always a shunt or a ETV is necessary. Yes, but we have some case that the difference for me, Jeffrey, is if we plan to put a shunt, we must be sure that the infection is completely resolved. Yes, but by ETV is not necessary. We can do the ETV even if the CSF show not some signs of infection. This is my experience, and sometimes it's worked very good.
That's very useful. Well, I think we'll turn our attention to some of the other questions, which are very thoughtful, but I think we probably ought to move along. Artur, I think you had said in coordinating the program, and again, for all the participants, Professor da Cunha gets credit because he very adeptly put the program together this morning. So my gratitude and congratulations for putting together such a great program with such excellent speakers that have such great experience to share with us. Is Tatiana's talk next? Great. So yes. Great. Tatiana, can you can we introduce and ask you to share with us your expertise now, please?
Yes.
Welcome, friend. Great to see you. Yes. Tatiana will be talking about hydrocephalus in the unique setting of craniosynostosis, which is an important subset and a very important domain of hydrocephalus management. So, Tatiana, it's great to see you. Welcome to the webinar, and thank you for joining.
Thanks a lot. Hi, everybody. So, first of all, I'd like to thank Jeffrey Blount and Artur da Cunha for this kind invitation and the opportunity to present our experience in hydrocephalus in craniosynostosis patients. And when we talk about hydrocephalus, actually we are talking about raised ICP because of CSF accumulation. But also when we talk about craniosynostosis, we are talking about stenosis of the sutures, premature closure of one or more sutures that also can lead to raised ICP. So they are two complex subjects together. And when we talk about the incidence of hydrocephalus and craniosynostosis, we can notice that hydrocephalus, the incidence in non-syndromic patients, is estimated in 0.28% of the cases, which means that is almost the same that in the regular and normal population. But when we look at the old papers that show the presence of hydrocephalus in non-syndromic form, we can notice that they are complex form, brachycephaly when both of the coronal sutures are closed, oxycephaly. So we are talking about multisutural craniosynostosis. And at the time, and this is a paper from 98, so at the time, the molecular diagnosis was not as we do today. So probably these patients were syndromic patients that could not be classified at the time. And we know that these syndromic forms are related to multisutural craniosynostosis, and hydrocephalus is one of the cases that contribute to raised ICP, which in the syndromic patients is estimated in 30 to 65% of the cases. And why is that? So several factors can explain raised ICP in this population of children. For example, the cranial cerebral disproportion, the skull base anomalies that can lead to airway obstruction and raising ICP. Also, these abnormalities in the cranial base can lead to tonsillar herniation, can lead to abnormal venous outflow, leading to hydrocephalus. But when we look at this photo, we can understand that all these factors are intrinsically related. So, for example, venous hypertension can lead to hydrocephalus, but also hydrocephalus can lead to venous hypertension, and that's why this is so complex. And when we talk about hydrocephalus, there are some theories that explain the presence and the incidence of hydrocephalus in cranial synostosis. So when we have a lot of theories to explain a problem, it means that we cannot explain with all of these theories. So that's why we have a lot of explanations. So at the end, we have three major theories: the venous theory, the constrictive theory, and the foramen magnum stenosis theory. And all of them, they are based in these school-based anomalies. So we know that Hoffman was the first to relate the small posterior fossa with cranial synostosis. And Chinali and co-workers in 1995 showed that the premature closure of the lambdoid sutures could reflect in the premature closures of synchondrosis of the cranial base. And this could lead to jugular foramen stenosis, foramen magnum stenosis, and also stenosis of the subarachnoid space. So when we talk about jugular foramen stenosis, so we know that when it happens, the result is this, is the persistence of fetal sinus and also the formation of venous collaterals. And this can lead to venous hypertension. And as Ramiro said, the CSF will be resorbed by this venous system. So if we have venous hypertension, it's easy to understand how it can lead to hydrocephalus. But, however, we have this important paper from Necker that analyzed the jugular foramen in Apert, Cruzon, and Pfeiffer syndrome and compared to a normal control group. And they showed that only the Apert group was the group that had a true narrow jugular foramen. So when we think about it, we know that the Apert syndrome group is the group that has less hydrocephalus and less venous anomalies when we compare to Cruzon and Pfeiffer patients. So that's why we cannot explain all of the cases of hydrocephalus looking only to the jugular foramen. And also in our department, we study 45 subjects with Cruzon, Apert, and Pfeiffer syndrome and complex cases. And we study the school base, and also we study the venous outflow and hydrocephalus, and we could not relate the school base anomalies with the vascular score and neither with hydrocephalus. So this is one example, is a Cruzon patient. We can notice that there is jugular foramen atresia. We cannot see the fulfilling of contrast in this region. And we can notice an important abnormal venous outflow in the occipital and mastoid area and also in the condylar area, and a small posterior fossa. And we can notice that this patient presented ventriculomegaly, but he didn't present hydrocephalus. So we performed posterior vault expansion and frontal orbital expansion, and no hydrocephalus was present. So and when we see this case, we can notice that the jugular foramen stenosis and the venous hypertension can explain ventriculomegaly, but in this case, why this patient didn't present hydrocephalus. And This is another case. So a jugular foramen atresia, we can notice tonsillar herniation, we can notice an important abnormal venous outflow, and also these patients didn't present hydrocephalus before or after surgery. And this is the same that happens with achondroplastic patients that present intracranial, intravenous hypertension, and they present ventricular dilatation once the resorption will happen by a hydrostatic pressure difference, but they actually don't present hydrocephalus. And when we look at our population of patients with hydrocephalus, we can notice that we have patients with severe venous outflow and hydrocephalus that needed treatment. We can have patients with moderate venous outflow and hydrocephalus, but also patients with just a mild, non-important venous abnormality and hydrocephalus. So we could not relate all the cases of hydrocephalus to the venous theory. So the constrictive theory, it says that once we have multiple sutures closed, we will have a small posterior fossa, and this can lead to problems in the flow of CSF, especially in the aqueduct, as Ramiro also showed to you. But when we look at the papers that study the CSF flow in cranial synostosis, in Apert, Cruzon, and Pfeiffer syndrome, we can notice that they don't present aqueductal stenosis. All the papers shows the flow in the Sylvian aqueduct. So also this theory cannot explain all the supratentorial hydrocephalus that can be present in these cases. And also this paper from Necker study the volume of the posterior fossa and the volume of the cerebellum, and they didn't show any difference between syndromic and non-syndromic patients, showing that it's not the volume, only the volume and the changes in the aqueduct that will lead to hydrocephalus. And we have this theory of tonsillar herniation. So Chinali and co-workers showed in 1995 that lambdoid suture closure will be expressed also in a synchondrosis of the cranial base, leading to a small posterior fossa. And this will lead to tonsillar herniation. And this sign, which is called the Coupe de Serre sign, that we can notice that the form of the posterior vault is changing because the posterior fossa is really small. And they related the tonsillar herniation in 70% of the cases of Cruzon patients, half of the cases of the Pfeiffer syndrome patients, but less frequent, more or less frequent in the Apert group. And also they related the tonsillar herniation to the presence of hydrocephalus. And this is actually true when we look at the venturi effect, which means that we have the same flow, but a region that is smaller. So downwards, these stenosis will have more flow and less pressure. And upwards, we will have less flow and more pressure. So this can explain the intracranial hypertension, and also hydrocephalus can be related to this tonsillar herniation. So this is one case that is a non-syndromic patient, but a complex cranial synostosis, is a Mercedes-Benz type cranial synostosis with premature closure of the sagittal sutures and the lambdoid sutures. And we can notice that this patient presents tonsillar herniation and ventricular dilatation. And when we perform the posterior vault decompression and releasing this tonsillar herniation, we can notice how the ventricular size change, controlling ventriculomegaly and stopping a possible hydrocephalus that was going to happen. And that's why nowadays we start the treatment of syndromic patients with the posterior vault expansion. And here is a case that we use the springs to perform this posterior expansion. And we can notice how the tonsillar herniation is released and non-hydrocephalus is seen. But so we think that if tonsillar herniation is related to hydrocephalus, so all of the cases with tonsillar herniation will have hydrocephalus, but it's not true. So here is our data. We have 100% of patients with tonsillar herniation in the group of severe venous outflow, but only 25% of these patients presented hydrocephalus. So as I said, none of the theories can explain all the cases with hydrocephalus. And when we look to the Apert syndrome group, it's important to talk about genotype because, for example, this is an Apert syndrome with a mutation in the codon 253. And when we look to this exam, we can notice that there is no tonsillar herniation. There is a moderate venous abnormality. The jugular foramen is big and open, and the patient presents ventriculomegaly and not hydrocephalus, didn't need treatment. But when you look at these patients with Apert syndrome and the mutation in the codon 252, we can notice that the patient presents a moderate abnormal venous outflow, not important. We can notice that the jugular foramen is big and open, and it feels really fine with contrast. And this patient, after decompression, he presented augmentation of the subarachnoid space, and after an important dilatation and symptomatic hydrocephalus and needed treatment. So this leaves us with this thinking that here we don't have an important collateral circulation, we don't have jugular foramen stenosis, we don't have tonsillar herniation, but we have hydrocephalus. And this other case makes us think a lot about genotype. So this is a case of Munch syndrome. But at the beginning, we thought that was only a plagiocephaly, but because we can see here closure of the coronal suture. But in the time of frontoorbital advancement, the patient arrived with this important deformity. And so we can notice more sutures that were closed, the metopic suture also. And when we perform the frontoorbital advancement, the patient presented this important hydrocephalus. He had just we can see a mild Chiari, and we perform also a posterior vault expansion, trying to control this dilatation, but it was not enough. It was symptomatic, and we performed the ETV, and with a nice flow in the post-op exam. And when we look at the literature, before Munch syndrome was related as a benign form that doesn't need a lot of surgery, doesn't need multiple steps of surgery, and doesn't present hydrocephalus. But in this recent paper, we can notice that the same mutation of Munch syndrome was related to a family with hydrocephalus, but without craniosynostosis. So sometimes we have a genotype leading also to hydrocephalus, and we have to count on this when we talk about the syndromic form. So how about the treatment? So this is a case to explain this treatment. This is a Cruzon patient. There was a clear blood shadow which is a really complex form of craniosynostosis. So we can notice an important Cooper-Beaton sign in the cranial vault, an important abnormal venous outflow, jugular atresia, tonsillar herniation, and ventricular dilatation. But as this patient has had extrusion of the globe and we needed to preserve the vision, we started the treatment with frontal orbital advancement. And after this advancement, the patient presents a really important symptomatic hydrocephalus. And here is the pre-op and this is the post-op. So we can notice how the size of the ventricles has changed, and we perform a VIP shunt. And look at this problem, because the VIP shunt leads to a cranial cerebral disproportion, which is what we want to treat when we talk about craniosynostosis. And that's why that nowadays we perform ETV in these cases, of course, when the anatomy is favorable. So here is the Munch syndrome that I showed before, and we can see the mammillary body. We can see here the floor of the third ventricle, and we could perform ETV with no problem. And after we opened the floor of the third ventricle, we can notice that the flow is really important. And this is the MRI in the post-op to show the flow in the prep-pontine cistern, showing a good result. So how we perform today our protocol. So this is the protocol of the Lyon department in France, and we agree with this protocol that in syndromic 4, when we start with the posterior cranial vault expansion, when we don't have an important exorbitism, and if the patient after present active hydrocephalus, so we will see if the anatomy is favorable to ETV. If it's favorable, so we perform the ETV. If it's not favorable, so we have to perform VP shunt. And if ETV doesn't work, so we go to the VP shunt. And the success of ETV is described in this nice paper from 2010 that I leave here to recommend this reading. So to take home message, the association of hydrocephalus to simple unisutural, monosutural craniosynostosis is really estimated as in the normal population is a fortuitous event. But in syndromic form, the pathogenesis seems to be multifactorial, and it's really important that we perform more investigation looking after the molecular changes and relating these to this type of syndromes for us to create better guidelines, better protocols for our patients, and leaving the message that ETV has a good success in the treatment of hydrocephalus related to craniosynostosis. Thank you.
Thank you, Tatiana. Nice presentation. And now Nelsie stay as coordinator of the rest of the webinar. Nelsie? Hello, Nelsie.
I'm mute, please.
Okay.
Artur. Artur?
Yes, I hear you. Hello.
You're muted now, Nelsie.
Are you listening me?
Yes.
But on my computer, I am without video and without voice.
Okay.
But if you are listening me, okay, I can talk.
We are listening.
No, Nelsie, now you are muted.
This is no problem. Yeah. Linda.
Can you unmute him?
Alô, Nelsie? Alô? Não, não tá dando.
Não tá dando para.
Ok. Então bota só o som, talvez, para ver se... Ok. Ok.
Que tem que fazer isso para mim. Não está conseguindo funcionar aqui.
Now it's working.
Nós estamos...
Now it's okay, we are
Yeah,
listening.
now we can hear you, Nelsie.
Ok,
Yeah,
I will talk on by mobile and see by the computer. Are you continue listening me? No.
Yes.
I think she's frozen.
Yes.
Linda, vou chamar ela por aqui.
Hello.
Linda.
Maybe it's better to take the
Continue.
video out.
Yeah. Linda, could you listen, Nelsie? If you can't listen, Nelsie, can you put the other presentation?
Yeah, sure. I can put it on already if you want. Would you want to put the presentation on first?
Yes, please.
Okay.
Thank you.
Now you can listen me and see me also. Hi, Linda. Tatiana, are you listening me?
Yes, I'm listening. You are a
Oh.
little bit frozen, the screen, but we are listening.
Okay, it was frozen screen for me and impossible to do video and voice, but if you are listening me, it's perfect.
Yes.
Congratulations for your wonderful lecture. The algorithm is a little bit complex, but complex craniosynostosis needs a difficult choice time to time. And what about your first?
Linda, I think Nelsie has a bad connection.
Yeah,
I don't know
think
if
so
Ramiro is here.
I see Ramiro. I can start the video from for Adrian's presentation first.
Yeah, I think it's better. Yes.
Yeah, okay. Let me just do that.
I'd like to thank the Educational Committee of the ISPN for organizing this interesting webinar. So today, we're going to talk about complications in ETB. So most of us would like to think that an ETB is a procedure where you just put in a balloon, dilate the floor of the third ventricle, and then you're done. Most often, this is one of the procedures that can be associated with significant morbidity and mortality if you don't know how to do things right. And of course, the most feared complication is the rupture of the basilar artery. So you might ask, why is Dr. Caceres giving this lecture? Well, I would like to say that to start by stating that the definition of an expert is that person who has experienced himself or witnessed every possible complication related to procedure, and therefore has learned how to avoid it, has learned how to deal with it, and is capable of preventing others from reproducing such complication. And in that aspect, I think through many, many years of practice in neuroendoscopy, I can sincerely tell you that I have seen many, many complications. So this is very important that we as neurosurgeons are honest. Not every single case is what is shown in the book. So Pepe Shinali in 2007 classified complications by its outcome. So success is defined as when you don't need to do any additional procedure. Partial success when the partially objective is accomplished, but further procedures are required. Success but reoperation for the primary objective. For instance, you do an ETB and the child persists having hydrocephalus and then you have to insert a shunt. Or complete failure when you have to abandon the procedure. What are the contributing factors to complications? Of course, inexperience and malpractice. Many people think that an endoscope is a very simple tool, and it is not. Sometimes you go into the OR and then you have a non-surgical scrub nurse who has no idea what all the armamentarium that is going to be used in the case and how to use it. Sometimes the equipment is not available because it's contaminated, and then you have to use combinations of several scopes and tools, which is not often the ideal scenario. And of course, HD optics and monitor can suffer malfunction before, throughout, or at the very end of the case. Of course, the position of the endoscopic tower is critical in order to have a clear sight of whatever you're doing. And the position of the patient and the endoscope holder are critical in order to prevent accidents. And of course, the type of endoscope holder that you're using might also be a contributing factor in order to keep your endoscope stable and preventing accidents, such as plunging into the brain whenever the endoscope holder is released. So this is a diagram. It's called the Swiss cheese diagram. So it says that a complication for it to happen is when all these factors align, and even though it's very difficult for things to happen, sometimes a number of events are combined and then you end up having a complication. So we know that the overall complication rate of ETP is somewhere around 6 to 20% with a global rate of 8.5. 4% of all neuroendoscopies lead to posterior termination. 3% are due to hemorrhage. And of course, the more severe complication, which is vascular artery injury, it's found in less than 1%. However, this can lead to significant neurological sequelae and even death. So the stages where an ETD can go wrong is when you insert the endoscope and you're trying to acquire ventricular access. 2, once you're within the ventricle, navigating within that cavity. Then the injury to the pillars of the fornix or other structures in the endoscope trajectory. Inadequate identification of the tuber cinereum. Difficulty when perforating the floor. Vascular injury to vessels in the preportine cistern. Inadequate perforation of the liquid membrane. And inadequate CSF circulatory progress, or even a fistula through the surgical incision. So we have spoken about the importance of having a good line of sight, having all your instruments and the scrub nurse and anesthesiologists who are familiarized on the setup for neuroendoscopy. And we know that sometimes, even in the best cases, you can have factors that limit a good image. Number 1, are you seeing the real thing? And although this might sound funny, we know about a case where an ETB was being performed and OR tech pushed the button, and unfortunately a video from a previous procedure was being shown. So the surgeon was completely unaware that what he was watching was a video from a previous procedure, and therefore, this led to a terrible outcome in that patient and became a legal case. Number 2 is the camera oriented. As you know, the camera can rotate, and then up can be down and left can be right. So always, before you insert the endoscope, look around with the scope in the OR rooms to know that you are properly oriented. Sometimes the system is not well coupled, and in the middle of the case, the camera detaches from the lens. Sometimes even the best lens can be damaged or become foggy, and then vision is not optimal. Blood deposits that are left on the lenses sometimes can stain them. Of course, we all have experience when you put a scope into the brain and you have brain debris at the tip of this endoscope, which precludes a good vision. And active ventricular hemorrhage is something that will transform the CSF fluid, which is normally crystal clear, into this cloudy or smoky appearance, which precludes adequate vision of the structures. So let's start by going about some of the most frequent complications. Whenever you insert a scope, you can either access the ventricle using a ventricular catheter, which is made of celastic, and therefore it's a soft structure. You can use an endoscopic trocar, which can also be made out of elastic. And of course, there are many ways to reach the ventricle. If you have neuronavigation, by all means use it, especially whenever you have tiny ventricles. This is the neuroendoscopic trocar, which is a peel-away sheet trocar, which we can use to insert certain scopes. These have depth guides, and of course remember that you should reach the ventricle around 5 centimeters maximum, and that if you're beyond 7, you are most likely near the skull base. Of course, certain scopes also have depth markers in order to assist with the concept of how far in are you inserting. Please use neuronavigation, as we have said. This will facilitate the entry into the ventricle. And sometimes one of the tips is that as you insert a large scope, please rotate it. So if there's any vessel near the tip, you can kind of gently push it aside, and in order not to overstretch it and rupture it. So I think one of the most interesting concepts is that whenever you're inserting a scope, you're doing it through a borehole, and a borehole is just a tiny space with a big universe on the other side. So always be mindful that you have very little control of what happens through that borehole once a complication has taken place. This is a study done by Stefan Wolfsberger from Vienna. As you can see, Stefan, what he did, he traced trajectories to trying to figure out what's the best entry point, mapping out the anterior and posterior margins of the foramen of Monroe, and then a trajectory that goes straight into the tuberosynarium. This point in the skull where the scope should be inserted, interestingly enough, can even go 2 to 3 centimeters posterior to the choroidal suture, and it's still safe in order not to hurt the motor strip. So once you have inserted the scope, this is one of the very frequent complications. There's a vessel that was ruptured during ventricular entry, and now you see this so-called blood drain that's coming from the top. And of course, if you retract the scope, it's going to even make it worse. On some of the cases, brain debris can accumulate, and then it's impossible to see a thing. In most of the cases, then you should pull out and reinsert the scope. This is another case. Now you have gain access, and there's debris in the tip of the scope. Sometimes by retracting the lens and reinserting it into the cannula, you can rid of this. Sometimes by irrigation, but sometimes these little pieces of ependyma are really adherent to the endoscopic sheet, and they become a problem. So you sometimes even have to use your forceps to pull them out. Bleeding immediately obscures your vision.
Lá no Empresarial que eu tô, na Ilha do Leite, ali perto do Esperança.
Always be mindful whenever you're working in tight spaces. And of course, you should be mindful that disease never studied anatomy. So there is a very, very high chance that the ventricular system will never look like the rodent book, or So this is an image of the tuber cinereum of a patient with myelomeningus. So here you can see interhypothalamic adhesions that are completely abnormal. It's really hard to tell where the mammillary bodies are and where the bacillary artery might be. Another example, you have thick membranes. It's you might think that this is a good place to pierce the floor of the tuber cinereum according to the deck triangle, but sometimes it's really tough. What you should know is that sometimes these interhypothalamic adhesions can be safely cut without having any significant deficits in the child. Another example, where the surface of the floor of the third ventricle has a very acute angle. Another example of a very thick interhypothalamic adhesion. Now, always, whenever you're doing a case, always try to see the anatomy of the basal cisterns. In this CT, it is very obvious that the tip of the basilar artery is exactly in the middle of the tuber cinereum. And here you can see how it's really hard to tell exactly where the bacillary artery is, but if you start looking around and you're using navigation and you've seen your studies, you can see that the artery is actually beating right there in the middle of the deck triangle. So it's not a good idea to pierce this structure. We went in front of that beating structure very carefully. We perforated the floor and then we dilated it with a 4AT balloon only to find a very, very acute angle of the artery. I'm going to speed this just in the sake of time, but look, the position of the artery is almost horizontal, parallel to the floor of the third ventricle. So be very careful whenever you're doing these cases. This is another case where we're dilating structures, and you can tell that in this child who had a previous infection, the basal cisterns are really, really thick. We're trying to dilate them using the Fogarty catheter, so in order to be as gentle as possible, but sometimes it's really, really hard, and you can actually feel the tension around the balloon. So sometimes it's a good idea to desist, because if bleeding occurs, it's going to be really, really hard to see through this structure. So it takes a lot of time and practice to master these tissues and to know when to go ahead and when to stop. This is another example of a very thick Lilliquist membrane and how sometimes you have to go even below it in order to do several distal perforations below the membrane of Lilliquist. But of course, the tip of the scope is really close to the bacillary artery, and this is where injury can occur. In this other case, always remember that you should not be adamant. This is a case where a patient who had a posterior fossa tumor was found to have this intraventricular metastasis. So if you're going to remove the tumor from the posterior fossa, it makes no sense to try to remove this little metastasis. just for the sake of, feeling good about it, that, oh, now you're very well versed and capable in neuroendoscopy. So we should try to avoid doing these kind of procedures that can put the patient at risk. So how do you manage bleeding, which is the most important factor? Well, whenever you're doing an ETB and you let the balloon deflate and you see that there's bleeding, immediately you should reinflate. And sometimes after waiting a couple of minutes, those tiny capillary vessels have already coagulated, so you can freely release the balloon. If you have persistent bleeding, you can do the channel technique as described by Heinrich Roeder. You can try to put the tip of your LOTA sheet as close as possible to the bleeding vessel, and then you can irrigate and work as a single chamber, isolating the bleeding area from the ventricular cavity, and then you can easily coagulate the tiny vessels that are causing the bleeding. This is a case of a child who had a very large pilocytic astrocytoma, which is protruding through the foramen of Monroe. Here we're going to take a biopsy, and of course you can actually tell by the color of the tumor that it's very well vascularized. So after the second specimen, you start to see huge bleeding. And now one of the things that we're doing more and more is using what we call the dry field technique, which is basically inserting a catheter and slowly start to drain the CSF from the ventricle. And as soon as the blood comes in contact with the air, you will see that nicely you will have a blood clot that is formed on top of the bleeding point. And then you can safely take samples from the tumor without fearing that blood is going to obscure your CSF. Arteries in the basal cisterns. And of course, sometimes you want to go in and try to use the scope as a dissector through the basal membranes. This is a case where we can see some adhesions in the basal cisterns. There you can see some rootlets of the cranial nerves, and you're looking around and trying to dissect these adhesions. But at 6 o'clock, you can see the bacillary artery that it's actually pulsating below the tip of your scope. And sometimes that tip or that lens has a sharp end. And as you're retracting away, you will notice that sometimes you were leaning too hard against that structure. So be mindful of that, because this is when disaster can occur. As I'm receding with the scope, you'll notice that I was pushing actually quite dramatically on the vessel, so be very careful. You are retracting, then you can have severe bleeding. This is a case that was kindly lent to us by Shlomi Constantini. He is a famous Israeli neurosurgeon and now the president of the ISPN, who always says that neuroendoscopy is the kind of procedure where by the end of the case, and most of the time, the child is fine and the neurosurgeon is in the ICU. This is another video by Kenichi Nishisama from Japan. He's working very close to the basilar artery, and there you can see again, significant bleeding. So of that bipolar can actually rupture the bacillary artery. So be very careful with the tip of your instruments, and always remember that we're working within very delicate structures. Sometimes these instruments can actually injure the walls of the fornix, and this can lead to permanent memory issues. So you have completed your ETV, but now your fornix is really contused. So try to avoid that. And use So just to finish, some post-ETV morbidity. It is said that 1.4 can have neurological morbidity, such as oculomotor paralysis, transient disturbances of conscious, hemiparesis, or memory deficits. Sometimes, if you're poking too anterior, you can hurt the pituitary axis, and then you can have diabetes insipidus, obesity, or precocious puberty, or a deficit of growth hormone. Sometimes when you have diabetes insipidus, most of the time it's transient. In just 1/3 of the cases, these can lead to permanent deficits. And of course, it behaves as any other surgery within the hypothalamic area. You can have a triphasic response. Some other morbidities, sometimes you can have hygromas after ETB. And we know this as the ventricle collapses away, you're actually doing 2 ventriculostomies, one in the fourth of the third ventricle and one on the cortex. So sometimes fluid goes into that space, and cortex falls away from the skull. It is said that you can find post-ETB hygroma in up to 26% of the kids lesser than 1 year of age. And the causes are, of course, the disproportion of the brain and skull, the abrupt decompression of the ventricles with the collapse of a very thin mantle, the lesser resistant pathway. Sometimes it's easier for the fluid to exit the ventricles through the cortex than through the floor of the third ventricle. And of course, immature absorption mechanisms. Hematomas. It can be found that these collections can actually transform hematomas in up to 1.4%. And of course, these are post-hygroma transformation hematomas that will require drainage and sometimes subduroperitoneal shunts, which we were trying to avoid in the first place. Intraoperative, some patients will develop tachycardia, some patients with hypertension, some patients will develop bradycardia. So always listen to the anesthesia machine and be very careful whenever you're putting in fluid, just to make sure that it's exiting adequately. Hemorrhagic accidents are basically associated with thalamic trauma, basilar artery trauma, and it has been described that you can have sudden late death. So always, I think the trick here is to know your anatomy, study your patient, and use a number of things in order to make your ETB work. So in the interest of time, I will say that the best way to avoid complication is to know your anatomy, know what the basal cisterns contain, know the structures such as the liquid membrane, know every single instrument you're going to use, go through a list of how the procedure are going to be done. If you have neuronavigation, please use it. Test all electronic equipment prior to the incision. Open and close all scissors just in order to make sure that they're going to be working once you're within the patient. And of course, always remember, whenever you have a hammer, not everything is a nail. So just because you have an endoscope, no, not everything has to be done endoscopically. With that, I would like to conclude and thank the audience for your kind attention. Thank you so much.
Thanks our audience for being with us. Excellent lecture from our friend from Costa Rica, Adrian Caceres.
about avoiding complications of TB is really very, very important. Maybe learning at the beginning, but start avoiding complications since our first step. It's important to do the timeout every surgery to be. We have the patient is available, is ready. The patient is the right patient. We are on the right side. We know this anatomy is a good case to do endoscopic colostomy or endoscopic procedure. One of the last slides that Adrian showed us is not mandatory to do endoscopy only because you have the set to a training for it. It's very, very important to choose the right patients. What's better for the patient, not necessarily what I would like to do for this special patient. And he shows also how to deal with bleeding. Bleeding, usually you can solve the bleeding with just irrigation, but he shows other options. But there is a question related to this bleeding. Is necessary to stop surgery? Time to time, yes. Time to time, we need to put AVD in place, but it's very exceptional to need to move to an open surgery. Usually only irrigation, or at the end of the day, it was necessary for us to do AVD after endoscopic ventriculostomy last week. And we left in place for 2 or 3 days, and it's okay, it's done. Artur, thanks for the privilege to share the webinar with you, Jeffrey and Linda. Thanks for all the speakers, the wonderful lectures. Do you like to do some comments for the question when you indicate ATV and when you indicate ATV plus CPC is one of the questions on the box. If you can do some comments, please.
Thank you. In my experience, I think that one of the best indication for ETV plus is the children in the first of life, but normally there is a group that we are not very good. So only with ETV, yeah, we have between 30 to 40% of tourism, but with CPC we can have 60% of good results. This is a good indication for and by chest malfunction, especially in case of sick ventricle or patient that had for a long time a shunt, I prefer to do this ETV plus CPC because this is also a group that we normally ETV alone don't work very good. This is my experience. Of course, yeah, we need more case, we need more experience. We do now here in the university a very nice study, and I hope that in 2 years we have the answer for this question.
Thank you, Artur. Linda, can you hear me better now, or still not good?
No,
sound?
you're a bit better, but
okay. Just a comment about Ramiro lectures, the indication for hydrocephalus treatment. When we have aqueductal stenosis, is the better indication for ATV. But also, like Artur stressed, the ATV success score from Kulkarni, we need to consider age, etiology, and previous shunt. It's only a personal feeling. If my possibility to have success on the surgery less than 50%, I prefer to do a VP shunt first. and not if I have the possibility to have success in only 20-30%. I prefer to do straight a BP shunt. And when the BP shunt have some kind of failure, indicate at that moment endoscopic third ventriculostomy. And just a final comment on ATV-CPC. For the papers from Benjamin Moore, the best success on ATV-CPC is when the child have more than 2 months and a half and less than 2 years of age. And the indication is more or less the same that we use for ATV. Some comments on the Tatiana hydrocephalus on craniosynostosis is on our day-by-day routine to do a BP shunt. When we have a craniosynostosis, when the anatomy is favorable, he shows in the papers also put in evidence that ATV can solve most of these cases. I'm not sure if the other speakers are on the audience. I am on the mobile. I can see the other speakers if they are on the room and if they would like to do some comments on final remarks.
Hi, Nelsie.
Yes, Tatiana, please, if you can do this for your lecture. And,
yes, and there are some questions from the audience that they ask how to manage bleeding and how to manage lesion of basilar artery. And I think we are lucky that we don't have a lot of experience with basilar artery bleeding, but there are sometimes we have bleedings that they are not too important, but they can stop our procedures. So as you said, EVD sometimes is necessary, and sometimes we need to stop and wait and see. But one possibility is to perform the dry field technique, but we don't perform dry field technique when we have huge hydrocephalus, only when we are doing ETV. But when neuroendoscopy can be used in many forms, and you can use to operate tumors, also to perform biopsies. And when we have important bleedings that come from tumors, we can perform this dry field technique that will empty the ventricles, and this will lead to the coagulation to happen. And after, we can control better than washing, because we can irrigate, but we have a limit, and we cannot irrigate a lot with a lot of pressure because of the risk of it. So it's just to tell them that this is a possibility, but not, for only for an ETV. Sometimes we have bleedings that we can just with irrigation, and also using the balloon in the membrane to stop the bleeding. This can be also helpful. And just to say that ETV and CPC changed a lot our experience with hydrocephalus. And we discussed here today hemorrhage, infection, craniosynostosis, coagulation of choroid plexus. So this showed how neuroendoscopy is useful for pediatric neurosurgeons. Nelsie, we cannot hear. Your...
You're hearing? Okay. Just to remind, thank you, first of all, and our audience. All the webinars are available online 24 hours or 7, and you can go in and see again these wonderful webinars. May we have other speakers on the room? or we are only us, Tatiana and Rita?
I think it's only us. Cannot see Ramiro now.
Okay. Linda, did you have the MCQ questions to put for the audience? Keep open.
No, not for for today. We said with Jeff that we were going to start this from January, from the next sessions. So for today, this is we're good to go.
Thank you very much for staying with us. Thank Linda for your support, and thank you for all the speakers. And especially gratitude for Jeffrey and Artur for restart these young doctors webinars. See you the next time. Bye-bye.
Thank
you.